the efficacy of antipsychotics in dementia. In the United Kingdom, they claim that the number of patients in rest home care who are receiving antipsychotics is diminishing. I'm doubtful about that, actually. But the problem is that there's little evidence that they make a heck of a lot of difference. And there's a high placebo response. And as I say, as Adam said, that the only risperidone is registered in New Zealand for use in dementia. There's no evidence for quetiapine or for any of the other neuroleptics. But in fact, in my practice, we tend to use olanzapine in preference to risperidone, which I don't like because it causes a lot of extrapyramidal side effects. So the British practice guidelines suggest that these should be removed after 12 weeks. And that's ideally, I'm sure, correct, but practically it probably doesn't happen. Medications have side effects. You're all aware of that, and particularly in the elderly and the vulnerable. You can list all the side effects, including probable with antipsychotics that you get accelerated cognitive decline, stroke risk is increased, mortality is increased, let alone all these other nasty side effects potentially. Benzodiazepines, patients get sedated and fall. Antidepressants, you can get hyponatremic and so forth. So really prescribing is, as it is everywhere in medicine, it's balancing the burden versus the benefits, and that can be really difficult towards the end of life. So if your stroke risk is increased threefold and your mortality is increased 1.5-fold and the accelerating cognitive decline, what are we doing with antipsychotics or major tranquilizers in the very elderly? Do they merely aggravate the dementia, cause more loss symptoms, as this is stating, but accelerate dying? They maybe improve the quality of remaining supported life, but they may accelerate dying. Now the question is that a good idea or a bad idea? And I'll let you mull on that one. What do we do about dementia violence? In our ward, every few days a nurse gets assaulted. Even I've been assaulted, and you hit with a handbag. I was hit with a nice right that came from a Russian former KGB agent, which was a bit... So why do patients become violent in these? I mean, there's multiple factors. Frustrated, they misunderstand, they're disinhibited, they're impulsive, they may always have been stroppy. It may be an unfamiliar environment that they're perceiving. They may have a grievance about a staff member or a patient or a relative. They may actually be frankly psychotic. Diffusing techniques are fashionable, but do they really work? They do sometimes, but when violence becomes extreme or the risk becomes extreme, it can be really difficult to even attract the attention of the person who's potentially being violent. How effective is pharmacology, apart from sedation? What about restraint? It's not fashionable to restrain patients. There are guidelines, but do we allow nurses to get beaten up because we won't restrain our demented patients? Is that fair? Is that in their work? Is that in their job description? Do they get compensated for that? I don't know what's happening in Wellington, but I also run a concussion clinic, and I guess in the last year I've seen 3 or 4 nurses who have been beaten up at work by patients. Is that acceptable? Is society really going to allow us to do this? Not to restrain our patients? It's a huge issue, really, that is too hard to think about, I think, for health authorities. What about resuscitation? I mean, we have to ask our demented patients and relatives if they want to be resuscitated, or if they don't, or more particularly if they don't want to be resuscitated. And yet, if you look at the literature, it's incredibly in effect, unsuccessful. It's a futile intervention in someone with an advanced neurological disease. It's undignified. It causes fractures of the sternum and all other sort of complications. I would suggest, and it's the same in hospices actually, that CPR should be the default, should not be the default position in dementia units. You know, the main reason for CPR in dementia wards is for the relatives and the staff, not the patients. We've got no chance really of resuscitating patients who have a heart attack, who have advanced dementia. Hopefully we've got a wee chance of resuscitating staff members. I walked out yesterday of the ward with one of the male nursing staff who had 90% occlusion in his main coronary vessels. Fortunately he wasn't at work, but he said when he presented to A&E and they wouldn't let him go home. And he was operated on the next day. Well, he was off to work the next day. I mean, he could easily have had a heart attack at work the next day, and he would have been worth resuscitating. But, you know, should our patients be... What about pneumonia? Pneumonia mortality's, according to this survey, is really very high in the demented, 53%. Antibiotics don't make a lot of difference because they may get you through that acute phase, but whatever caused the aspiration is going to reoccur, so that they're going to get pneumonia the next week. So when do you stop treating it with antibiotics? I think in palliative care generally, if someone's distressed with pneumonia, with respect to respiratory distress, then we might treat them with antibiotics. So the question is pneumonia old man's friend? Okay, well, one of my favourite papers in medicine is this one. William Osler, 1896, 124 cases of pneumonia. No other disease kills from 1/4 to 1/3 of all persons attacked. He's saying in 1896, you know, this was a killer, but in fact he forgot to mention that 3/4 to 2/3 survived. And this was before antibiotics were invented. So though Osler was saying that so fatal is it that to die of pneumonia is said to be the natural end for elderly people, pneumonia is a self-limiting disease. It runs its course uninfluenced in any way by medicine. This was before antibiotics. So actually when you look at this from over 100 years later, what he's really saying is that pneumonia has a very low mortality rate.
I think you could question that actually, because he's talking about a population of people who were considered old at 40 to 50, whereas we're looking at a population that we would consider old at 80 to 90. So I think it's apples and pears myself.
Well, you can argue that, yes, but also, well, anyway, fair point. And certainly our experience, or my personal experience in palliative care, is that pneumonia often presents as uncomfortable for a few days, and then lo and behold, the person survives. It's not the killer that we assume that it is. You know, it's not a knee-jerk to race into antibiotics, is one of the questions I'm raising. What about suicide? Well, I think it's already mentioned the suicide risk is pretty low actually. Some Draper in Sydney says that it's not even increased. I think there are exceptions, and I spent a lot of my career attending Huntington's disease, and it's certainly higher in Huntington's disease, but in the early stages, before the patients tend to get decent symptoms, if you like. And I think it was high also in HIV in the early years of the epidemic. So it would seem that impaired competence, in other words dementia, is protective against suicide, except, and I think this was raised this morning, unless the person's also depressed or alcohol's involved or drugs are involved. So the reality is that requests for euthanasia and dementia care are extremely rare indeed. As I say, in 33 years of seeing Huntington's patients, I've only known 2 suicides and 1 Huntington's patient actually requesting euthanasia. Very surprising. What about artificial nutrition? Does tube feeding improve survival? Well, I think there's good evidence to say that it doesn't. And it's associated with significant patient harms, particularly quite a significant increase in the risk of pneumonia because you get reflux. And particularly in demented patients who may not be able to look after their PEG site hygienically, you can get a lot of infections there. So I think the Gillick would say that it's appropriate only if the dysphagia is temporary, which of course it isn't in advanced dementia. There are situations where it may be appropriate, but generally speaking I would argue that it isn't particularly appropriate. Pain, well, it's really hard to assess pain in dementia, particularly when the person's lost their ability to communicate verbally. Many old people, I think they're sort of more stoical than maybe the young people, often don't like to use the word pain. So sometimes if you use a slightly different word, they sometimes acknowledge that actually they are a bit sore. There's a wee bit of discomfort there. We know that pain tolerance is enhanced in Alzheimer's and advanced dementia, but it's really difficult to ascertain. You've often got to rely on behavioural expressions of pain rather than the person volunteering that they're in pain because they've possibly lost their ability to communicate verbally. So I mean, I think the rule there is if in doubt prescribe analgesia. But I think it's also important to realise that even some of the simple things that we do in medicine are quite painful. This was an interesting study done way back in 2009 now, 10-point numeric rating scale. So when you put down a nasogastric tube, no surprising, it's only 6.9 out of 10. I would have thought it'd be 9.9. Taking blood, 4.6. You know, it's quite a painful and nasty experience, particularly for demented patients. Putting in catheters, intramuscular injections, restraining, even moving from a chair to a bed for a demented patient, it's quite painful, it's quite unpleasant. Having an X-ray, for example, even having vital signs taken, or even waiting. So I guess that Mitchell was really saying that, you know, we often forget how obnoxious some of the seemingly simple interventions that we do. And you know, why do a chest film if you're not going to treat the pneumonia? Why take blood when you're actually doing it for academic curiosity or to validate your clinical impression, when, as I say, it causes discomfort? Advanced care planning, it's really fashionable these days, but it's problematic really. Theoretically, it's a great idea, but particularly in dementia care, it needs to be done before the person's sick. The biggest problem, I think, is what's called the disability paradox, that actually people change their mind when they get sick, so that I may have a view today to say if I had advanced multiple sclerosis, was in a wheelchair, you know, please kill me. But when I get advanced multiple sclerosis and I'm in a wheelchair, my view may be quite different. And when you go round, I learned this many years ago when I was looking after a brain injury ward, and the CPR stuff came in, and we had to go around and ask all the patients, this was people with very severe brain injuries, whether they'd like to be resuscitated or not. And I told the nurse, the charge nurse, I said, they'll all say they want to be resuscitated. And she said, no, they won't. So she went round and 100% of them said, well, of course, I'm not a vegetable. And yet they were in hospital permanent care, incredibly disabled. So that's the disability paradox. When you get sick, you change your mind. It's all very well having a view on abortion or euthanasia, but when you actually have the disorder, very often the patient's view is quite different, and that's a problem with advanced care dementia, advanced care directives. You know, they have to be dynamic, they have to change, but it's really hard to keep up with the deterioration of physical health very often. Organic regression induces survival behaviours. I mean, as Hurlings-Jackson would say, that the more primitive functioning that you're working on, like an animal, the more you want to live. So apart from the mythology about lemmings, I think, jumping off cliffs, which is probably incorrect, most animals, when they're injured, will fight to the death, really. And I think humans are the same. And certainly in oncological care, there are a few patients who seem to have enough cognitive reserves and the will to die when they want to die. As soon as you see patients with brain secondaries or dementia, they don't. The other problem we have is with enduring power of attorney. Generally speaking, the surrogates are very conservative. Surrogates make conservative decisions, and that's problematic, I think, particularly if the surrogate is in the same generation as your patient. You know, so it's a matter of trying to persuade enduring power of attorneys to be completed by the children and not the spouse, the younger generation. But even so, they will tend to, if push comes to shove, say, treat rather than not treat, for example. Advanced care planning, particularly in Belgium, to a lesser extent in the Netherlands, if you make an advanced care plan that if you get advanced dementia, you want physician-assisted euthanasia. As I say, probably some of these patients may well be change their mind, but that doesn't matter. If you've made the advanced care plan in Belgium, you're not allowed to change your mind. So that's a bit of a problem. This guy's a bit of a problem too. That's a young picture of Bob Hawke, who said that if I were to lose my marbles, I would want he said he'd want his wife, with the help of the GP, to end things. So here's a former Prime Minister of Australia saying if he becomes demented, he'd actually want physician-assisted euthanasia. I would say it'd be interesting to see Bob Hawke now, because he must be quite a lot older than this photograph, what his view is. But I would suggest that it may be that he might change his mind. What about, and I think this is quite commonly seen, is the very dutiful, usually wife or daughter, who's looking after the demented patient incredibly conscientiously, but maybe not in their interests. And I don't know how you get around this one. And sometimes I think you see elder neglect in relatives who would be horrified if you suggested that they were actually neglecting their mother or their father. But sometimes their care is so rigid and so by the book and so unreasonable that it probably does amount to. What about some of the emerging epidemics? I mean, I think this is a huge problem for us, and if you've got a spare moment, Robin Williams' wife wrote a fantastic article about her husband's Lewy body dementia and decline in neurology. It's a wonderful article. And I'm always a little ambivalent about it, recommending it to patients. And I was with a patient just this week, with a relative of a patient who had Lewy body dementia, and I said to them, well, you know, this is a fantastically good article, but the problem is that, of course, Robin Williams committed suicide. So the trouble is using it as education, is that the end result is not necessarily the one that you would seek. Of course, Muhammad Ali is a classic example of that disorder, dementia of boxers, and it's becoming incredibly high profile, I suppose, with concussions and sport, American football and chronic traumatic encephalopathy, which is probably a variant of Lewy body. What about palliative sedation? You know, it's relatively straightforward, I think, in oncological palliative care, where people can make a decision, the patient can make a decision, preferably, that they would rather be sedated than endure a last few days of excruciating pain or shortness of breath or whatever. The problem in dementia is that we have an incompetent patient, so you can't really negotiate with the patient as to whether or not their preference would be to be asleep or awake. And this, you know, there are risks associated with this, and it's expensive, because actually when you palliative sedate patients, they live longer than if you don't palliative sedate them, by a few days. So it's an expensive intervention, as a matter of fact, and contrary to the public's belief, who think that we knock off patients all the time by giving them morphine. Morphine never kills patients unless they're drug addicts, and there's other reasons for that. But for oncological patients who are on opioids, for example, it's virtually impossible to give yourself an overdose of an opioid. You've got to be using something else. And benzodiazepines likewise are incredibly safe. So how do we define what is intractable suffering, which is really the indication for palliative sedation and normal palliative care? How do we define that in dementia? Because, as I say, from our perspective, the patient may well be intractably suffering, but not from their perspective. So to go back to Our Lady, the cicada, you know, she was on quite a significant dose of various medications and a syringe driver over the last couple of days. But look, she took 21 days to die. The difficulty in neurodegenerative disorders from palliative care perspective is time. It's very different in cancer care, where you can pretty accurately predict within a few days people's longevity. It's really hard in neurodegenerative disorders, and that makes it really complicated and expensive and so forth. So I just finished by Richard Smith, who of course was Australian, but he was actually the editor of the British Medical Journal for probably 20 years, defined dying. He claimed that dying of cancer is the best death. And of course, when you present this to oncological palliative care nurses, they sort of vomit really and give you an argument. But his theory was that sudden death's good for the victim, but not so good for the survivors, because they haven't had a chance to digest it. Dementia's the long, slow, and probably the most awful way to die, he reckons. Organ failure, well, you end up in acute hospital beds and zealous junior medical staff keeping you alive. Whereas with cancer, you've got time to complete the tasks, reflect, prepare, and say goodbye. So I guess the message there is that, you know, this is really hard from a palliative care perspective. So I suppose the take-home message is, you know, one of the huge challenges is that if we provide good care, particularly good nursing care at the end of life for demented patients, and enhance, do we actually enhance the quality of their remaining life, or do we just merely prolong their dying? I don't know the answer to that.